everyone. Thanks for joining us for our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here at Phoenix Children's Hospital, and today we're joined by Dr. Cynthia Wetmore, our new division chief for the Center for Cancer and Blood Disorders at Phoenix Children's. Thank you so much for joining us today. It's great to have you here. You've been here, what, 2 months now?
Just about. It's
okay.
Week 7.
Okay.
Yep.
Getting there. We're very happy to have you here, and thank you for joining us. September is Childhood Cancer Awareness Month, so we're very excited to be celebrating all of our patients this month for our Time to Shine campaign. We both have our garb on this morning, so thank you for tuning in, and feel free to ask any questions along the way, and we'll make sure we get them answered for you. All right, so let's just dive right in. Tell us a little bit about you. Where did you go to school?
Thank you. Well, I'm very pleased to be here. I am originally from Minnesota. I grew up in Minnesota, and I went then to college at Harvard University in Boston. I went back to Minnesota for medical school at the University of Minnesota. I then went over to Sweden for 4 years, where I did a PhD in neurobiology, because I was very interested in how damage is repaired in the nervous system and how cells divide. I then returned to Minnesota for the rest of my medical school, and then I went to St. Jude Children's Research Hospital for my fellowship.
Okay.
But between I guess I should say I stayed in Minnesota for my pediatric residency training, which I did at the University of Minnesota and Mayo Clinic in Rochester, and then I was at St. Jude. Okay. And
wow, so very different weather this winter for you.
Very
in
different.
Arizona.
Very different, yes. I'm looking forward to it getting cooler.
I bet. When you joined the faculty at Mayo Medical School in 2001 as an assistant professor, you founded the first multidisciplinary clinic for pediatric brain tumor patients. Is neuro-oncology the main oncology field that you focused in?
Yeah, my privilege has really been to care for all pediatric oncology patients, but my area of special training and interest is really caring for children with brain tumors. And you're correct, I was at Mayo Clinic in faculty for almost 10 years. And while I was there, I had a basic research laboratory that we were studying how cells divide in the nervous system, and specifically how a pathway called the sonic hedgehog pathway plays a role in medulloblastoma. And I developed the first mouse model of that tumor that we used to help understand how different drugs kill tumor cells that might be helpful then in curing childhood cancer. Clinically, I was at Mayo, yes, and I developed the first interdisciplinary clinic. So we had neurosurgery, endocrinology, radiation oncology, pediatric oncology. So we had all the subspecialists come to the patient room, really, and we could discuss with colleagues, and so the patients didn't have to run all over the hospital
nice.
To see the different subspecialists.
That multidisciplinary care approach, that's really appreciated by families, I think.
It's good, and it also helps keep us on task because we are able to be much more efficient with our rooms and scheduling, and so the patient is not wandering around and the physician waiting, because we have the patient there, and so the physicians can come through and see the kids.
Yes, that's great.
Yeah.
So it sounds like you're pretty passionate about research. How important is research in pediatric cancer patients and to Phoenix Children's as an organization?
That's an excellent question, Stacy. Thank you. Research is absolutely essential to improving clinical care. I think that all parents, we want to take our kids to hospitals that provide the best evidence-based care. And none of us wants to think our children are being treated with therapies that are 5 and 10 years out of date. So in order to always keep things moving ahead and also test the best practices and the best drugs, we must have research. We do clinical research, we do clinical studies. It's important to have basic science research so we can understand, for example, if you look at a tumor tissue, what genes are mutated. That is discovered in a basic laboratory, but then in order to understand how you can target those mutations with drugs, that's more translational research, and so we need to have some of that translating from the basic lab to the clinic, and then we need clinical research as well to know if the drugs that showed so much promise in animal models and cells grown in a culture dish, if those drugs actually work in humans, and that's what the real research comes down to, whether or not the patient benefits.
Okay, so it sounds like it's twofold, that translational and then the clinical.
Right, and I think that Phoenix Children's, it's essential to develop a robust research program here, and that's one of my passions and one of my roles in coming here. I think that Phoenix Children's Hospital is a fantastic, one of the top-rated hospitals, but many of the studies that we have here are studies that were also generated out of collaboration with other centers. We want to be the destination here so that we will have the cutting-edge breaking research that we develop here at our hospital, and then other hospitals will come and want to collaborate with us.
That's great and very important for the patients.
It is important for the patients. It also allows patients to be able to stay home in the valley here and receive the cutting-edge therapy. They wouldn't necessarily need to travel to the east or the west coast for that.
Yes, definitely. And so we touched on a little bit of those targeted agents. Tell us a little bit about clinical trials. What are some of the benefits? How do patients qualify? How do you select the right patients for the right trials? That sort of thing.
That's good, and I think it's an important question, and every trial is generally different. There are several different clinical trials, and I think it's important for families to understand that we are not running experiments on their children, but we know that a drug, once it gets to the point of a clinical trial, we think that that drug has great promise, and it's shown activity in killing tumor cells in the culture dish, sometimes killing tumor cells in animal models. And so it comes to clinical trial, and it's important that those trials are done at a very experienced center. So the children then are recruited, or families are presented with an opportunity to join a clinical trial. And different trials have different criteria. So, for example, some trials are available for children with leukemia, because if we have a drug that's very promising in leukemia, but perhaps not for brain tumors, it's not fair to provide it to brain tumor patients when we feel that it doesn't have much potential for benefit. Okay. So the most important thing in a clinical trial is that it's done safely by experienced physicians, that the families understand what their potential benefits and also some of the potential side effects. Some of these drugs have never been tested in children yet, and so children may have different side effects than adults may have. One of the studies that I'm conducting in adults, one of the side effects was diarrhea. But the kids seem not to be fazed at all by it, and most of the children that take this drug don't get the diarrhea. So it's important that these studies are done by experienced centers. Another important criteria for enrolling in a trial is making sure that they have good organ function. So make sure that their kidneys work, make sure that the liver works fine, because some of the therapy that we give our kids causes damage to hearing, to kidney, to heart function, and we want to make sure that if those kids that have received prior therapy and already have some compromise in their kidney function or heart function, that we don't want to make them worse. Most importantly is to keep the children safe. So we often have certain parameters or certain blood counts that we feel helps keep the children most safe. The other thing is the clinical trials, they're always opening and closing, and there are new drugs and new trials and new strata opening, and so it's important for the families to stay in very close communication with their physician. We're able to tell a family we think that there are maybe 2 or 3 studies for which your child might be eligible, but it's very important that then we continue communication, because there's often a window of time where that study will be open and allow for new patients to start taking the therapy, and then it often closes. And the reason it closes is to be extra safe and make sure that we analyze the patient's body function, analyze their blood counts, analyze how they're feeling, to make sure that we don't just keep pressing ahead without understanding if the child is having benefit or any harm.
Okay. Is there a typical length for a clinical trial? Does it just kind of vary?
Often some of the early phase clinical trials, they're open probably for 2 years or so, because it takes a period of time to go through the different dose levels and get an answer to the trial. If it's a phase 1 trial or a phase 2 trial or a phase 3 trial, they may be different times that those trials are open.
Okay, and what are the differences between a phase 1, phase 2, and a phase 3?
Very good question again. So a phase 1 clinical trial is generally the first step of a trial being open in humans. Okay. So it's that the drug has been tested in the laboratory. We often test the drug on cells or tumor cells that are growing in a laboratory dish. Sometimes we test the drug actually in mouse models of human cancer. We estimate what the dose will be. Usually the drug is tested then in some adult patients with different cancers. And it's important to say that pediatric tumors are often very different from adult tumors. So we can take information, though, from the adult studies and then devise a safer and more child-friendly type of study. And so the first step of studying a drug in humans is considered phase 1. The role of a phase 1 study is to determine what the recommended dose will be for ongoing studies. A phase 2 study is then the next step of a drug development, and that is using that established recommended dose, using the dose. So all the patients then generally get the same dose, and then we test whether or not it's effective in different disease subtypes.
Okay.
And a phase 3, if the drug succeeds in going through phase 2, it will then be tested against the gold standard in a phase 3 study.
Okay.
So many phase 3 studies enroll hundreds of patients, and a lot of those are large consortium studies, like through Children's Oncology Group or other consortia.
Okay, so it's a progression.
You're right.
Okay, thank you.
Much more concise.
No, that's perfect. Great explanation. Thank you. I had no idea what the difference was. What are some of so you're our new division chief. What are some of your main roles and responsibilities, and what are you most looking forward to?
Well, my biggest joy is taking care of patients, really. I love taking care of patients, and I'll be taking my own brain tumor patients in the outpatient clinic. I will also be doing inpatient service. In that setting, I'll be taking care of all the hematology and oncology patients that would be in the hospital, as similar to my colleagues in taking our rotations. I'm also really looking forward to coming to know the staff and the physicians here. It's a wonderful group. You've given me a tremendously warm welcome, and I look forward to working with you and continuing to improve the care of our kids with cancer. We are very excited to be moving into brand new clinic space. We will have brand new facilities, and there are adjustments that need to be made and processes, so there are bumps along the road, but it's going to be wonderful to be in that new space.
Yes, new space in October, so look forward to that. It's very exciting.
I also look forward to continuing to build the reputation and build the quality of care that we provide here at Phoenix Children's Hospital. It's one of the largest children's hospitals in the U.S., and I think that the more we can grow and improve our quality and processes, the better care we can give, and the more new novel therapies we can provide to our kids so that they have the cutting-edge therapy. And I hope that one day Phoenix will be actually a destination medical center, and so that children will come from all over the country and perhaps the world to come to Phoenix for the cutting-edge care for cancer and blood disorders.
And I think with the research and the clinical trials, we'll be well on our way.
We are well on our way. It's such an exciting time, and with the ability to sequence the human genome, we're also on the cusp of really leading a consortium of hospitals where we'll be able to actually sequence the patient's tumor compared to their normal DNA, and we can understand what mutations are present in the tumor so that we're better able to select therapies that might be of most likely to benefit the children.
That's great.
Sort of fast track to a fingerprint of your tumor and picking the right drugs.
That's so fascinating that we can do that.
Well, we're almost there. Right now, we can detect the tumor mutations, and then that can suggest certain drugs, but we still don't know if those drugs are effective. So it's very important once we figure out what drugs might be effective, we need to look at it in a systematic way, like a phase 1 study or a phase 2 study, so that we're able to build on the knowledge and be sure that we're doing it safely and with the best care of our children in mind.
That's great. Earlier you touched on the importance of having pediatric providers for pediatric patients and having those pediatric patients come to a place where they can be treated, because adult tumors aren't necessarily the same as pediatric tumors. So can you touch on that a little bit about what it means to have a place like Phoenix Children's where we have dedicated specialists devoted to pediatric patients and what that means for those patients?
Yes, we're very fortunate to have a robust hospital here with many subspecialists. It's very important that children are treated age appropriately. So, for example, a 30-year-old or 40-year-old or 50-year-old adult may have very similar physiology. But in children, a 6-month-old baby is dramatically different than a 2-year-old and dramatically different than, say, a 16-year-old. So we have very different, very rapidly changing body function, developmental status, and it's important that we have physicians that are aware of those changes. We also need to provide the most excellent care for our children, and just because they have a brain tumor, which, for example, a GBM, glioblastoma, it appears under the microscope, whether it's from an adult or a child, it looks the same under the microscope. But we know that there are dramatically different pathways involved. So we can't take a drug that was developed for an adult brain tumor, a GBM, and expect that to be as successful in children. We have very specific mutations, and it's important that the physicians caring for the children know what the specific differences are present in a child's body. And also, we have the risk of harming development. We know that many of our drugs are not good for normal dividing systems and normal developing children. And we want to be sure to reduce the toxicity as much as possible, because we want to be able to kill the tumor cells, the cancer cells, but not harm the normal cells as much as possible.
Okay, wow. We had a question come in from a user. Are some cancers passed on genetically?
Yeah, that's an excellent question. Yes, there are many cancers that are passed on genetically, and so that means that the tumor cells arise because of sort of a precursor mutation. There are certain mutations that are passed on from parent to child, or there are some tumors that actually develop in a child spontaneously, but if they go on and develop and have children, it may be passed on. So it's very important when a tumor is diagnosed in a child that we take a very careful family history. Okay. Most tumors still arise just de novo, meaning the mutation occurs in the tumor cells and is not passed on genetically. So most pediatric cancers arise de novo as brand new mutations. But if certain tumors arise and they arise because of a germline or a genetic mutation in all of the cells in their body, it's very important that we understand that so that we can give that patient the best possible care. We may need to do some special screening tests to look at other parts of their body. It's also important, if the tumor does have a genetic predisposition, that we check any siblings. Yeah. It's also sometimes important that the parents know if they may carry a mutation that makes it slightly more likely for a tumor to develop. It might be important for them to know. Okay. But it's very important to work with your physician and make sure that you ask those questions and get those questions answered.
That's great. Thank you. Very great advice. Let's see. Next question. So the Center for Cancer and Blood Disorders here at Phoenix Children's is one of the largest pediatric programs of its kind in Arizona, and it provides complete care for children diagnosed with malignancies and those hematology diseases. What areas of oncology and hematology does the center specialize in? So neuro-oncology, leukemia, what are those different programs that we offer to patients?
Thank you. We have a comprehensive program, so we offer care for all types of cancer and blood disorders. We have one of the largest blood disorder center in the country. We treat hundreds of patients with sickle cell disease. We treat hundreds and hundreds of patients with bleeding disorders, hemophilia, clotting disorders. We have a very robust program with specialists that have very special subspecialty expertise in certain types of bleeding disorders. Mm-hmm. We are in the process of developing a consult service that we can help do consults throughout the hospital if a child has a blood clot. So, for example, a child may have a blood clot, develop a blood clot on the surgery service, or may develop a blood clot on the GI service. Mm-hmm. Then the other consulting services will ask us as hematology oncology specialists to come and investigate why that child had a clot. And so it's important that we provide expertise across the board. We also have comprehensive oncology programs in leukemia and lymphoma, solid tumor, brain tumor, sarcomas, and we're able to treat really any type of cancer or blood disorder available. We have therapy here available for every type.
That's great. We had another question come in. Is Evans syndrome a genetic condition? Did I pronounce that correctly? Yeah. Okay.
So Evans syndrome is a rare genetic disorder that has certain mutations and certain inconsistencies within the immune system, and they develop different types of disorders in the blood or leukemias. It is a genetic disorder. We believe that it's arising from a genetic mutation.
Okay. So one of those that falls under that category.
Yeah.
Okay, perfect. Thank you. Right. So we already touched on the various cancer types that the program offers, so thank you. I think it's wonderful to have all of that comprehensive care under one roof, so patients don't have to go somewhere else if, something doesn't sit right with whatever we offer.
Yeah.
So
another advantage that we have is that we have several satellite clinics throughout the valley. And so we're very privileged to have such wonderful nurses and staff and pharmacy people that help us serve children throughout the valley. And we're trying to build those programs so that we have the expertise available at the East Valley and the West Valley. Right now, a lot of our specialists are centered downtown, which is fantastic, but it's also not that convenient if you live farther out. And it's we're working to develop the program so that we're able to better serve the patients in the valley. We have a very robust hematology program actually in the Southwest Valley. It is very well developed, so many of those patients get the excellent care closer to home. But we're working to build our provider base and also expand our program so that we're able to provide the same excellent service in other areas of the valley.
And we treat not only pediatric patients, some adult patients as well, right, with some of our programs?
That's correct, especially the hemophilia program. A lot of our patients actually sort of age out of the pediatric range. Most people believe that pediatrics goes up until the age 21 to 22. However, I've cared for patients that are in their 30s if they have a pediatric type tumor. But we're trying to develop programs as well so that we're able to transition our adolescent and young adult patients. When they get to be 15 to 18 to 20, they may have actually more in common with adults and adult facilities. So we're working to develop a program to help transition our young people to go to adult providers. But we also provide care for adults. But I think ideally it's good for them to also establish connections to the more adult facilities in the area, and we're helping to provide ways to continue to treat and support them during this transition.
That's great. And we also have the survivorship program here too, correct?
Yes, we do. So we have the good fortune that many of our pediatric cancer patients do survive and go on to live long and happy lives. But we also need to understand that some of the therapy that they've received can cause harm as they develop. So we know that certain types of radiation therapy in young girls that have been treated with Hodgkin disease, for example, they may have a higher incidence of breast cancer. So we've reduced that type of radiation, but we still need to understand about the toxicity that the therapy may bring. So we have a growing survivorship program. We're trying to understand what problems pediatric cancer patients may have as a result of their therapy. We're also trying to counsel them. We're trying to improve research and understanding of ways that we can decrease the therapy and still have a very good cure rate, but not have the toxic consequences in some of these kids. For some of the sickle cell patients, it's very important that we have help with school and learning. Some of these sickle cell patients are at risk for increased risk for a stroke, so it's very important we support them in their educational plans so that if they choose to go to college or trade school, we're able to help them and counsel them and perhaps give them a little bit of extra help. And we learn these problems through our survivor clinic as well.
That's great that we offer that for patients.
We do. It's a very important program for as part of a comprehensive cancer center.
Yes. Okay, another question. Are there any studies coming the next 2 years to explore reducing the total treatment time for boys with ALL that you know of?
That's a difficult question. So we're always talking about ways to reduce therapy, reduce toxicity of therapy. We now know from sequencing of the tumors that there are many different subtypes of ALL. So for example, it's not just one disease. There are discussions in the Children's Oncology Group, and there are hopes that we're able to reduce the duration of therapy, but we want to do that very carefully so that we don't compromise the cure rate. Right now, some pre-B ALL have greater than a 90 or 95% cure rate, and so we are very careful we don't want to reduce that duration of therapy because we know by extending that duration we've been able to achieve that excellent cure rate. But we're always trying to reduce the time and the intensity of therapy. So yes, there are several groups looking at that. I am not aware of the timeline at when they will open.
Okay.
I can't promise that they'll be open in the next 2 years because this requires a collaboration of a number of different centers, and everyone has a different idea, so it seems to always take longer. But the goal is, yes, to reduce the intensity and duration of therapy.
Okay, perfect. Thank
you for that question.
Yes, thank you for answering that. One other thing you mentioned earlier about the satellite clinics, I know some of them offer infusions, correct, for patients? So talk about our infusion center here, as well as having access to those at the satellite clinics. And I know we're very excited about our new infusion center in the new space. So just touch on that a little if you could.
It's very exciting. So we have a brand new infusion center here at the hospital. It's located in our new clinic. We're opening on October 18th. We are going to have 15 or so infusion chairs, and so the children are able to have a reclining chair, a comfortable chair. Some of the chairs even massage during their infusion. So for patients that come in and need to have chemotherapy given or blood infusions, we also have some patients that come with other disorders where we provide expertise and give infusions, for example, patients with arthritis or Crohn's disease. But we have these infusion chairs at our new center, but we also are able to give infusions at the satellite centers, so that saves a lot of time, and it's better for the patients because then they can go to school perhaps in the morning or come early and get their infusion and then be back at school on time for lunch. So we're really happy to provide the expertise and the specialty care throughout the valley.
That's great, especially when they have those reoccurring appointments or infusions.
You can miss a lot
to drive back and forth
and wait. So we're trying to help with improving customer service and flow through and efficiency in our new space. We're all very excited about being able to provide even better, more efficient care to our kids and families.
That's very exciting. Okay, let's see. So you kind of already, the last question I had was the sneak peek of the new center. So is there anything else? I know we touched on the infusion space. Anything else around the new center that you wanted to touch on, or?
Yeah, we hope that, it's going to be fantastic new space. It's a lot more space than we have in the current ambulatory building, and we're hoping to have more efficient patient check-in, so the patients can check in and get right back to get their blood drawn. We're also going to be doing procedures starting a little bit later in the morning so that the children can have, especially the small ones, can have a little maybe apple juice or something early in the morning, and they don't have to be without food for so long. So we're excited about that, and the new space is going to be hopefully very efficient and friendly, with a lot of open spaces and bright lights that will help bring joy to our families that need to spend longer days there.
Very important part of it. Well, thank you so much. Was there anything else you wanted to touch on that we didn't get to talk about, or?
I'm just very excited to be here. I'm enjoying the slightly cooler weather, and I'm looking forward to having a long and happy journey here as we learn to bring better therapies to our kids with cancer and blood disorders.
We're all very excited to have you here. Thank you for joining us today. If you have any other questions, feel free to leave them in the comments, and we'll make sure to get them over to Dr. Wetmore.